OBGYN Society, and she's an expert matter on the subject of maternal mortality. And we are so happy that you have come to join us and show us your insight about the topic. Dr. Hernandez is also joining us. She's assistant professor in the Department of Community Health and Preventative Medicine in the Center for Maternal Health Equity at Morehouse School of Medicine. She has a various background in community-based research and is also a subject matter expert on the topic of maternal mortality. She, excuse me, sits on various national organization boards and was trained in Emory University, as well as a bachelor's from Stony Brook in New York, a New Yorker as well. Welcome, Dr. Hernandez, MD, PhD, MPH. Our last but not least is our political representative, the Honorable Park Cannon. She's in her fourth term as the youngest Democrat and youngest female member of the Georgia House of Representatives. She was elected to the House Minority Secretary in 2020, and she serves Midtown, Downtown, and Southwest Atlanta. Welcome, Park Cannon, and thank you for adding your words. She has to leave us shortly, so I'm going to cut to the introductions and kind of cut right to the chase. If I want to kind of go round robin with our questions and start asking you guys, what are your thoughts about maternal mortality? When you look at and read the topic, just looking at it, as Black women, we are more likely to die in childbirth and have complications. And why is that? We're strong, we're supposed to be continuing on the race, but why do we have so many operative complications and maternal complications? Is because of our race. It's because we have comorbidities such as we carry too much weight, we have hypertension. It's because we're not treated fairly in the hospital. What is the problem? I suspect that it's multifactorial, but how do we get started? If you can kind of give an audience a little bit about what you do. I'm gonna start with Representative Kansas, and she has to leave early, and give us your thoughts briefly.
Hello, everyone. It's really nice to be with these wonderful women. You are in for it, a lot of wisdom. And I know sometimes getting through all the titles and all of that is just, to get the conversation started. So I'm excited to be here, albeit a short period of time. As a legislator and as a doula, I'm a full spectrum doula, whether someone is continuing a pregnancy or not, and working in the hospitals here in Atlanta throughout this crisis. My first jobs were in clinics here in Atlanta and providing well women's care all throughout the time of being a legislator. It's so important that we do whatever we can within our wheelhouse to make the connections. So I think this conversation is a lot about the research that we've done and the work that we are putting in our own facets. So I wanted to share with you 3 pieces of legislation that we worked on this year, that we've been working on to continue this conversation on maternal mortality, which can really sometimes just be a traumatizing way to describe, the postpartum outcomes, whether they're positive or some of the situations that happen. So when I think about this, I really think about evidence-based implicit bias programs for healthcare professionals. And, even in our own communities, serving our own communities, we have to be aware of our biases because these are what, impact the positive outcomes. We also think about folks who are incarcerated. Take it from me, I always, have wondered about how, as a legislator, I could impact the penal system's impact on the negative maternal health outcomes, whether that be hysterectomies, whether that be, misdiagnoses of fibroids, whether that's pregnancy loss, all of those different emotional support pieces. So we also put together the Georgia Women's Care Act, which is Child Care Alternatives, Resources, and Education Act. That specifically was about making sure that if women are incarcerated, that they are not handcuffed behind their backs. and really digging into that system, which at times can be a difficult conversation to have. But many a times it's Black women shouldering that conversation in the advocacy world. The last one that I'll share is just continuing to expand Medicaid for what we call Mama Medicaid. We know 6 weeks was not enough. That's why last year we got the 19 million in for 6 months, but that's not enough. But the federal government is giving us reimbursement as a state right now for keeping mamas and families who have experienced pregnancy on Medicaid, which is great, but we still need to shore up those dollars in the state budget. So I thank you for having me, and I look forward to sticking around for a little bit more to listen to the other panelists.
Thank you, Representative Cannon. Caprice, can you give us some down and dirty numbers about what exactly is going on in Georgia? Because we always say, God we trust, but show me the facts, show me the numbers. What percentage of us are actually dying in childbirth? How many of us are having, complications of childbirth, whether it be hysterectomy, whether it be hemorrhage, which is bleeding after having a baby, causing you to lose your uterus at the same time, or whether it be, more as a stroke.
Thank you for that introduction, and I'm very pleased to be here with everyone, and thank you for having me on the panel. Maternal mortality is very near and dear to my heart. I work on it probably every day, and excited to be able to I'm like eat, sleep, and breathing maternal mortality, improving outcomes, but I'm passionate about it. The numbers are stark. In Georgia, we've had a maternal mortality review committee since 2012, and we were really out front with that. We're one of the first states to really have a comprehensive maternal mortality review committee and began reviewing deaths from 2012 until now. We're still playing catch up. Of course, it's not real time data, but the numbers that we do have in the cases that we have reviewed, the last data that I have is from 2014. We have completed the 2017 cases and just about done with 2018. And so we'll be getting those numbers and we'll be seeing those come out. One thing that there was a legislative subcommittee last year that wanted Georgia to catch up with those numbers, because we need to know what we need to do today and what's happening today and not 2014 and 16, because things have changed a lot. But the numbers are, in Georgia, we are the last data that we have 2.7 times more likely to die from pregnancy-related causes, right? Things caused by pregnancy that if you did not have those complications or issues in pregnancy, then you probably wouldn't have died. 70% of those are preventable. And that's the real stark sort of wake-up call, that 70% of those deaths are preventable. And so when we begin to look at what are the causes and the top causes that we've seen in reviewing our cases and continue today, and I think Natalie can attest to that. I served on the Maternal Mortality Review Committee from 2012 to 19, and the top causes for multiple years were cardiovascular, hemorrhage, and cardiomyopathy and preeclampsia. They kind of go together. And those are the top causes for our pregnancy-related causes. And now there are associated causes that, a little bit out of our control. And those numbers are, homicides, car accidents, and things that, sometimes happened not related to the pregnancy, but during the first year, a woman, between the time she had her baby and subsequently passed away. So that's kind of the way that we measure, if it's pregnancy related or associated, the timing of death usually within the first year of life. And those guidelines came from the CDC. And the CDC has put forth in sort of a monograph of information for us to be able to quantify what was the death pregnancy related or associated, and created sort of a dashboard to use to be able to do that. So that's how we kind of get our data, make our diagnosis, get to our causes as a committee, which is a very diverse committee of stakeholders from various doctors, from various public health, medical, education, academia, across the board, to be able to come together and review cases. So it's a very, we have the medical examiner, pathologist, so everyone at the table really trying to really get to the bottom of some of these. So The data is, and it hasn't changed, right? So 2 to 2.7 times here in Georgia, across the country, 3 to 4 times. And those numbers are, still challenging. And with COVID, we're going to see that those numbers have not changed, or maybe probably even gotten worse.
Probably increased.
Yeah.
Can you talk about the access to prenatal care in Georgia? Is that a guarantee? Not a guarantee?
Well,
And
well,
how easy is it to enroll in Medicaid? Because people think it's an automatic thing, and it's not.
no. No, Medicaid, you qualify for Medicaid if you're pregnant, right? So it's pregnancy related Medicaid. You can't get Medicaid any other time. So if you have diabetes, you've had hypertension, you've had thyroid disease, you've had anything, you probably didn't have insurance until you got pregnant. We will cover you if you're pregnant. And so Georgia, typically you can get on Medicaid once you establish the pregnancy, a pregnancy letter, and choose one of the 4 care management organizations we have here in Georgia to enroll with. It's accessible. There are, in our rural areas, we have obstetric deserts, right? So yes, you can get on Medicaid, but then your ability to be able to see a provider within 10, 15 miles is difficult because there is none. So we have these obstetric deserts where women don't have care. So yes, we do have the ability for women to be covered for pregnancy if you're a US citizen. It's covered for pregnancy up to, like Park said, up to 6 months now. After you have your baby, typically it was just 6 weeks. And so it's accessible. But again, when you're in rural communities and your OB is 50 miles away, it can become challenging for our rural communities.
And Dr. Hernandez, I wanted to bring you into the conversation. Since you served as chair of the Mortality Review, can you give us some insight about what your term and what you tried to accomplish? For the people who don't work in medicine, we analyze every death. We have a mortality, for every case that patient has a mortality or has a complication, it's analyzed. But to take a step further, what is the after action review, or we call it a root cause analysis, which is what I think your committee is tasked to do. If you could give us some insight on that.
Yeah, absolutely. So first of all, thank you so much. And secondly, I'm not the chair of the Maternal Mortality Review Committee. No, it's fine, but I do sit. I'm
speaking into existence.
But we do have some guidelines that are based off of CDC and what they require for us to look at. And so you're looking at, your medical causes. But what I like and what we're starting to do is look at all these other causes related to maternal mortality, which are these root causes, these inequities, these social determinants of health. So things that are sort of these macro level factors that really play a role. And then from there, as Caprice mentioned, 70% of the cases are preventable. And so looking for action behind it. So not, oh, this is the cause of death and that's it, but this is the cause of death. These are other factors that contributed to it. Now let's think about actions that can address those factors. So if the cause was cardiomyopathy, but we noticed that, a woman was in a care desert. So there, she was an hour and a half away from the nearest hospital. She had a lack of social support. So maybe she had something and couldn't reach someone to support her to take her to the hospital. I mean, there are all, as you mentioned before, a lot of the factors are multifactorial. And, it's about addressing everything in a way that can be comprehensive. So I think we're getting there. I think there's a lot of room for improvement. And that's why, we have these committees. That's why even as members, we're able to make recommendations. We're able to speak our minds. And, and as Caprice mentioned, we do like that it is multi-sectorial, that it does have representatives that are not just in the medical field, but people like myself, that's a social behavioral scientist that can really observe it from a new angle to fully comprehend what's happening to women in Georgia, but specifically to Black women. There are a lot of, we talk about structural racism. That's something that, if we weren't at the table, we wouldn't really be able to put out there, because sometimes, people put a blind eye to what's happening when it comes to structural racism. It's like the elephant in the room that no one wants to talk about. And and Representative Park Cannon mentioned that that a lot of these things are actually related to policy, and we need to go back. Sometimes we're trying to put a band-aid on a situation that took 400 years to happen. With the stress and the weathering and all of these things that are contributing to what's happening to Black women and other women of color, because we know that this is also happening to our Native American women, who also have significantly higher rates. And we're going to see this happen to other women of color. Right now, Hispanic women have high rates of comorbidities. They don't have high rates of mortality. But if we continue to have lack of access to care, which we know 20% of women still don't have access to care in Georgia, we didn't expand Medicaid, so there's still this coverage gap of people that can use the coverage to be able to prevent or get prenatal access, or even before that. Because again, when a woman is pregnant, it's too late. We need to take care of our women as soon as they're born, as soon as we can have some type of coverage to make sure that we're preventing these factors, that women are getting the education that they need, just the basic needs of life that can contribute to better health.
I think that's an important point that we talked about, mom Medicaid, but you need to be healthy before you get pregnant. So we have women walking around who have, very high blood pressures, who have diabetes, and then they get pregnant. And you can't reverse years of damage within 6 to 8 months. And that's why, expanding Medicaid is so important, so that we are healthier before we decide to get pregnant. And that's part that we're always, we're starting, behind before the baby's even born. We're already high risk at conception, which is something that has not changed. And it's, oftentimes getting worse with lack of access, community healthcare clinics not being accessible as they were, is that we are just unhealthier getting pregnant right now.
Yeah. And remember, 60% of births are unplanned, right? So it's not everyone is planning it. So you can't, have ideal optimal health when it's unplanned. Again, access to, reproductive health care, contraception is an issue here in Georgia. I mean, there's not a lot of, we do have a Medicaid plan called Planning for Healthy Babies, but, do communities really know about it? And women 18 to 44 are eligible for Planning for Healthy Babies, and it does take care of contraception. It takes care of up to 4 visits with an OBGYN. Then the OBGYN has to take that coverage. Women have to know it's available to them. It was a little bit complicated, was that the plan was even there. So some women don't know that it's there, and then what's covered by it. And then where can they find a provider? So is there comprehensive coverage? But then if women don't know about it or what, how to use it, then it's not really going to be as effective as it can be. So women need access here in Georgia to reproductive health services before they become pregnant. And that's a huge issue. We'll take care of you when you're pregnant, but we don't care about you before or after.
Exactly.
But then we want you to be healthy during the pregnancy. I'm like, well, how are we going to do that? We'll have insurance.
Yeah. So I think that's such a big piece of the puzzle, and it gives my OBGYN colleagues such a hard way to go when the patient is not in great shape, and they're trying to bring a baby into this world. So one question that was in the chat is, how do we measure maternal health, and why are we the highest across the globe? If you're Black in America, why do we die most?
So that
why are we the winners of that?
Yeah, it's a really interesting thing. There are a lot of theories related to it. I think what's interesting is that, even if we look at significant predictors of maternal mortality, we look at age, right? Because we know the older you are, the higher your chances are. We know that if you are on Medicaid coverage, that you have higher mortality rates. We know lower socioeconomic status, a presence of chronic medical conditions. But if you control for all those factors, no matter what you do, they still don't fully explain the differences between Black women and white women. There was a documentary around the social determinants of health. It was called Unequal Causes. And there was one instance talking about when the bow breaks, and it said a woman, Dr. Michael Liu has a lot of research around this, and it's a white woman who dropped out of high school still has better outcomes than a Black woman who graduated from college. And so we're trying to understand these things. Again, what people are saying is, there's a lot of stress related factors that Black women experience. So the everyday fact that you're a Black woman, that you're experiencing discrimination. Dr. Kamara Jones, compares it to like if you're, pushing the gas and you're gunning the engine, with Black women, blood pressures and all these things, are really contributing to it. But a lot of it is more around these structural determinants or this racism that's occurring. And we have research that's trying to identify it right now. The National Institutes of Health is putting a lot of money behind looking at structural racism. And I think particularly because of this racial awakening that the country had recently, I mean, think about it, being a Black mom, being a Black woman, knowing that your children may not come back home, knowing that you may not come back home if you go outside, and you look suspicious or you do something wrong. So there are a lot of different theories. I mean, there are things that we know, but of course, with any type of research, we need to have, huge representative samples to say this is exactly it. I think, again, with racism, people just don't want to talk about it. And it's something that I think now the country is going to start talking about and something that we'll start to realize. And we see it in other countries right now in Brazil. They're seeing that Black women have the highest maternal mortality rate, and they're actually calling it out and saying it's racism that's contributing to Black maternal mortality in Brazil. And hopefully we can get to a day in the United States where we can say the same thing and deal with these structural policies and then see better rates, because the rates are not getting better. The new CDC report came out and it said maternal mortality actually increased in 2019. So we have a lot of work to do. And I think it starts with people like Representative Park Cannon. It starts with really addressing it at the macro level and having policies that can really help our Black communities.
Yeah, and it doesn't help that we don't trust the system, right? So the system has not always done right by us historically, right? So you begin to look at historical perspectives and you begin to see that the system has not done right by us. And we know that as a community, we know the Henrietta Lacks, we know the Tuskegee story, we know, Sims, the gynecologist who, experimented surgical surgery on women with no anesthesia. I mean, those stories, we know about the Planned Parenthood, Margaret Singer, and, contraception in Black communities. So we know those stories. And so our level of distrust for the system also plays into this, because the system has not been right by us, we do not trust it, they do not trust us, and they don't believe us, and our voices are not really heard. And so there's multiple examples of that. You can see in the news and maternal death from multiple stories that women just were not heard, their voices were not heard, they were not acknowledged, their complaints were invalidated. And so that on top of all of what Dr. Hernandez talks about just really complicates the story for Black women.
And I hate to say it's all the system, but I think as, a Black woman, you have to speak up for yourself. We speak up when we get our hair done, when we get our nails done, this done, right? You go to the doctor, all of a sudden everyone's quiet.
It's a power dynamic.
I tell my patients, I said, my check is going to be the same whether you ask me a question or not.
I do too. I mean, I spend a lot of time, talking and, asking questions and getting people, but I think people are intimidated when they come into the medical space, and, it's your knowledge base is more than theirs. And so they don't think it's a stupid question. It's a dumb question, or, I don't want to ask that. Or they're going off information from family and friends and not really coming to the medical expert to really ask the information that they need, and not speaking up for themselves. And it's tough. You're vulnerable when you're pregnant. Your hormones are at play. It's just a vulnerable time. But, we need our women to be empowered. Like, no matter what, you have to speak up for yourself.
Dr. Google is ever present.
And it also comes from always being dismissed when you did speak up for yourself, right? Yeah. Always constantly being ignored. And again, there are studies to show. There was a study that was done. It's called Listening to Mothers, and 40% of women indicated that they experienced discrimination, and 24% of them said they were never heard. Like, they expressed their concerns, but no one ever heard them. And then it's also, it's also upon us as people, as educators, as physicians, as people working with our communities, to start teaching women how to do that, how to ask the right questions, who to contact, what are the levels of authority that you go through, because our medical system is also a very complicated system. I have a PhD and I still cannot figure out sometimes our medical system, and it just becomes more complicated as we have more payers, and there's just so much that's involved. And again, I think it's going to take a comprehensive approach, a multi-level approach to really getting at the root of the problem and helping our women, and I wouldn't say helping our women, but working together, because our women know what to do. They just need additional tools to be able to assist them to do that.
Yeah, and we did a little mini study. I was working on a Merck for Mothers project here, and we did a study, and our small sample showed that women, their biggest complaint is that they felt like the physician didn't listen to them, and they didn't really feel that they were a partner in making the decisions that they felt that were right for them. So that was really important, that they don't want someone telling them they need an induction and not really explaining why, and really giving them the information that they felt that they could really have a choice in, right? So you don't want somebody telling you what you need. You're like, no, why do I need that? Everybody will tell you get a second opinion, right? But when you're with your OB, where are you going to go for a second opinion? And if that's the only OB for 50 miles, you're stuck. Becomes difficult. The other thing that we really have begun to advocate for, one of the moms that did a video for us and worked on the project with us on respectful care, is that when you're laying hemorrhaging and bleeding to death, you can't advocate for yourself. But she had her mother with her. That's why we're trying to have a real push for doulas. You need someone else with you sometimes to be the eyes and ears, to speak for you when you can, and to know what your wishes are. So, it takes a village, right? To raise a child, it takes a village to take care of a mother. And so, we have to, when you go into those spaces, to maybe have someone that you trust, because, the physician almost gave her the wrong dose of medication. And so, it became very, like almost life-threatening. And then she says, if my mother wasn't there, I would not be here today. And so, it's just, those stories that you hear that make you realize that, yeah, you can speak up for yourself. But, in times of, when you're bleeding to death, or you might have a seizure in labor, you might have, when you're, having a crisis, you need a voice as well. So it's just,
and that is so,
about.
so important. And one quick question is, are they covered by Medicaid? How do you find a doula if you wanted to have one with you in the delivery room? And are they restricted by COVID as well?
Now during COVID, yes. A lot of hospitals will only allow one person in the room. A lot of doulas have had to go through, FaceTime and, being there in presence, on the phone. But you work with your doula. Doula is not there to breathe with you at labor. Your doula works with you from usually during sometimes the entire pregnancy, but the second and third trimester, to really get to know you, to learn you, and to learn you and your partner dynamics, and to really begin to work with you. Because, right, it's more than just having a baby, it's becoming a mother. And it's more than a physical, it's a physiological, it's a psychological, an emotional. So all of that needs to be worked on. And so it's not a doula to be there to breathe with you. It's a doula really to be your partner on this journey. And so, and I don't think Black women know a lot about doulas, and insurance doesn't cover it. Some private insurance will let you use your healthcare spending dollars. Cigna covers some doula services and lets you use your flex money and things like that. But Medicaid, that's still a battle here in Georgia. But again, we have to show the benefits, right? We have to show the data with the doulas for insurance to come around, So there's data there, but data to move the needle on the dollar. So that's what we are. We're pushing. We're pushing for that. New York has done it, and they've had some. We're pulling for New York to validate some of that data for us, so we could push in other states. So, but
and other states have it covered. Some states do, and they have really good models of how you do it. I think in particular, like looking for loopholes to the laws, like such as some states cover your community health worker. And so if you have a community health worker, some people see doulas as that role as a community health worker. They're providing information, medically accurate information, and also providing that support. And so there are some ways to do that. But again, as Caprice mentioned, we have a long way to go in Georgia and really figuring that out. And it's always going to take science and data to really move that needle in that direction. So I think there are good things happening and we can find ways to get around it. One of your questions related was, how do you find one? There are different groups where you can find doulas. I think, like you mentioned, Dr. Google, you can look that up. And there are different certifications, but then there are really more holistic type doulas. So it's also talking to your provider and seeing how do they work with doulas, seeing if there's a good connection, because it is a team-based approach to care. And your doula, if you're working with a provider, they have to sort of be able to communicate as well, if you want the best birth or best experience possible. So I think there are a lot of different ways to sort of get at that. And then there are also listservs related to, Black doulas. Sometimes we know that outcomes are better when there's physician patient concordance, or when people look like us, right? We respond better. They know our culture. There are things that work, like for my birth, I had Stevie Wonder. I wanted Stevie Wonder playing through the whole thing. I wanted a doula that was Black, that looked like me, that can, understood my concerns and stuff. And so that was something that I really sought out. And then women should talk to their doulas. It's a relationship, right? It's like dating. You do interviews. You don't just go with the first person you find, or someone because they're least expensive. Sometimes that can be to your detriment. You want to make sure that you have a connection with that person, because this is your life, this is your child's life, and this is your birth experience, and you can only get one of those at that moment. So again, you treat your doula like you would your physician, like you would your partner. All of these things are really important to consider when you're looking for a doula.
I have a couple questions in the chat if we could get through some of those. We talk about, I hate to say patients just don't know or they're ignorant. I just think our literacy sometimes is not where it should be on health related topics. When I go at Home Depot, I'm pretty much illiterate because I don't know what I'm looking at. I need to raise my literacy there. But when some people want to come in to see the doctor, the literacy is just not there about what is hemorrhage. What does a fibroid mean? What is C-section? So how do we increase our health literacy around childbirth, doulas, et cetera, et cetera? Is there a list of questions that we can take when we go see the doctor that are easily accessible that we can give to our audience, or what do you recommend them looking at when they're, finding an OBGYN? What questions should the doctor be answering?
Yeah, there's multiple websites. I think that there's Dr. Google, but there you can go on the medical websites. There's ACOG, there's the ACNM, the American College of Nurse Midwives, the American College of Obstetricians and Gynecologists. There's doula, professional doula websites. You have to go to places, March of Dimes. There's places to get good information, and then there's, the crazies out there putting out every story they can to make you scared and nervous. So you do have to be careful in the sites that you do frequent. But I think that you have 9 months to do your research. I think that it's important you do your research when you buy a house, a car, a toaster. I know I do. I'm buying a blender, and I'm on pots right now. I'm like, what pot should I get? How do they cook? I can't go in the store and just buy it. I gotta go online. I won't buy it yet because I want to go and make sure it doesn't have any chemicals coming off of it that I can get cancer from. So you do that level of research for the smaller things. When your kid goes to school, how anyone who's in Georgia knows the school search is like the hugest thing ever. You have to put that level of time and effort and energy into really giving yourself a comprehensive overview of all of what to expect while you're expecting. A lot of people now, I find when I go to deliver someone, I'm like, did you take childbirth classes? Nah. People don't take classes as much, right? They're on IG, they're on Facebook, they're on everything else, just taking in small bits of information. So, those sources you have to have reliable sources for women to be able to go to get their information, because that's how women are really taking in information. But you want reputable, reliable sites that have good information. I can't give you the total list of questions because, some people got some crazy doctors out there that tell them some crazy things. And so you kind of have to know where to go. If you have that, you have to have a friend, a mother, an aunt, a cousin, someone else who's had a baby to even bounce what you're thinking and what the physician is telling you. You don't have to address it at that visit. You can address it at the next visit, but you have to be able to, if you hear something, If you hear something, see something, say something, say something. It doesn't sound right to you. It doesn't feel right. You don't have to go along with everything. You have a choice. And so sometimes going to someone, a friend, an aunt, a mother, someone else, to really be able to sort out the information for yourself, your partner, your husband, how does that sound to you? And really be sure that you are armed with the most information. But, you know, we need to be a more proactive in our healthcare, right? It's our bodies, right? It's our temple. You have to be able to navigate when you need information that's going to benefit you and your babies, right? It's not researching the stroller, the car seat, the baby seat, and all of that. It's researching really the hospital, the physician, the C-section rate, you know, what does induction of labor mean, breastfeeding, hemorrhage, hemorrhage, what does that mean? Bleeding to death, how much? Am I anemic? Do I have high blood pressure? What do I need to worry about? Because high blood pressure is not high blood pressure just in pregnancy anymore. We're starting now to see that there is long-term consequences of having preeclampsia and hypertension in pregnancy. Women are at higher risk for heart disease later in life. So I tell my moms, you've had this high blood pressure in pregnancy, you take your baby to the pediatrician, they will not go to the primary care, because when they come to the GYN, they say, no, I don't have a primary care. They don't go they don't check on it again. They don't check on it again at all. So you're like, go check on your blood, check on yourself. I want you to take your baby, you take yourself. You had high blood pressure and you're at risk for heart disease later. I need you to take care of yourself, because this can be a problem later on. You go on to have baby number 2, number 3, number 4. That's where we're running into the issues. Yeah. Because now you've had those insults onto the body, onto the heart, onto the cardiovascular system, and you never addressed it. So it's serious.
Same thing with diabetes.
Same thing. Right.
Same thing.
That's right. So we're now starting to say the same thing for hypertension.
Now, can you give some tips? I know we're doing some virtual visits, and how do we navigate that when you're pregnant? If you have to do a virtual visit with your OBGYN, how do we, be more prepared for those visits? And how do we use the MyChart function, which is now pretty much widely available? You're able to see your medical records now. That just started, I think, the beginning of this year, that you can access your own medical record. And a lot of us who look like us don't use that feature. They don't use the MyChart. You can look at your own test results and everything else. It's no longer, I have to wait for the doctor to call me. You just can look in your MyChart and it's your information. You can access that. So how do we empower our patients to know that it's your information? And how do you, do a virtual visit, which sometimes, happens, especially the first week postpartum, they're just going to see you maybe virtually with this COVID environment.
Yeah.
I mean, you may not come into the office.
Absolutely. I think that there are, first of all, a lot of people just don't know about these types of resources. I didn't know about MyChart for a while too. And then there are providers that don't extend that service to their patients, or, let their patients know that these resources exist. And so I think, again, and it's going to sound redundant that it's education, but it's forums like this where we're able to talk about the things that exist to our women, and then spreading the word. We know that we're good at word of mouth, right? Oh, I heard this, and this, and that. Talk about these things, talk about positive experiences. Then there are also resources that are available. So Morehouse School of Medicine, along with the University of North Carolina, Reaching Our Sisters Everywhere, the National Birth Equity Collective, we all developed a lot of resources around telemedicine and telemedicine visits, and what to expect when you're going to have your telemedicine visit, particularly for providers, because sometimes we know that, sometimes a telemedicine visit may feel not so personal, but then it's also very personal because you're inviting people to your homes. And so how do you change your background so people may not see what's going on? What types of questions do you ask? How responsive should you be? How do you prepare? So we have those resources, and we can share that with people that are listening to this right now through the link. And then, as I mentioned before, just
Black Mamas Matter.
Yeah, Black Mamas Matter. I think they're a great resources. And then there's also Black Mom's blog. This woman created this blog because she said, there are all these books about what to expect when not expect, what to expect when you're expecting, but there was nothing that was really relative to Black women and their experience. And so she created Black Mom's blog. And so that's another wealth of experiences that connects you to other women who may be going through similar situations. There's always this assumption that it's me and my male partner, or that I have a partner, or that I have all these social supports. And with Black Moms Blog, here you build up social support systems. There are different toolkits. I mean, Georgia, the one thing that's amazing about where we live in Georgia is the community-based organizations that exist, that are led by Black women, that, that care about our women and are trying to do so much, but there's only so much you can do. And so I think, the organizations that exist, and again, that's something that we can provide after this, is a list of these really reputable organizations that are doing a lot to help women, partnering with them or seeking services where they're at, I think would be really helpful for some of the women as well.
Yeah,
there's a question in the chat regarding why do we as physicians ignore the woman's self-advocacy? I think that it's a difficult question to answer. I think a lot of times, physicians are often rushed because we're measured by how many patients you see in a day, and a new patient may only have 20-minute slot. So you have to get everything done in 20 minutes, order the test, do the exam, and wash your hand and get out of there. So they're you get into a routine like, okay. And you're kind of just trying to get, through that exam because you have to go on to the next patient. And you're judged on.
And they handle the 1 year of problems that they've had.
Yeah. And you're like,
what's the problem today? Not
I have 20 minutes to address this. And like, this is going to take an hour and a half for me to unpack. So sometimes you get caught and you just have to say, well, the schedules are screwed up, and everyone else is going to be mad at me today because I'm going to run behind, because one patient may say that something that's, really, really important, I'm bleeding, or I'm having chest pain, I'm feeling lightheaded, and you're like, oh, this is really going to screw up my schedule. So I think it's a lot of pressure on both sides, from the provider side and from the patient side. There's definitely bias by providers. We all have bias.
But that's where
black and white.
Black and white. We all have bias.
And that's where training is so important. I think, at Morehouse School of Medicine, we train our students in their first year on how to work with communities, how to provide respectful care from the beginning in their first year, even though they're memorizing, and learning about physiology and all, the body parts and all of this other stuff. A big part of what we do is we immerse them in the community. We teach them about how to care for community members. So training, and then also team-based approaches. So yes, physicians are super busy. So that's where you have a certified nurse midwife or doula who can come in and take that time with the patient to empower them, to give them the tools that they need to have a better care experience. And so that's why, again, we think there are a lot of pushes with policy on interdisciplinary training and approaches to care, and really thinking about team-based approaches. Because, one person can't do everything, but if we have a team-based approach, then we can get at it all. Yeah, I mean, it's overwhelming. It's really overwhelming, especially because half of Georgia's counties don't even have an OB provider. So, we have, people just going to the same people, and people are getting overwhelmed. And, we were in COVID.
And people were home. Yeah. And then, the reason why people don't have OB providers is because they just can't afford to do it. Because of practice insurance, and that really has not been addressed, why that still is, that people cannot afford to. I mean, to find a solo practitioner now is almost unheard of because you can't afford it.
You can't, because more than 50% of the births are Medicaid, and the Medicaid reimbursement rate for OBs is not the same as private insurance. And you can't keep your lights on, your gas on, and maintain a house in rural Georgia if more than half of your patients are on Medicaid, and Medicaid reimbursement rate is not a lot. You have to see a lot of patients.
A lot of patients to Medicaid. And honestly, hospitals bill for Medicaid for their big contracts, but they, the one who want to get to, the one who bids the lowest.
Yeah,
not the highest.
And the other thing I wanted to mention that Natalie was talking about, we have with training here in Georgia, there is a Georgia Perinatal Quality Collaborative, and we've been working on a lot of the top clinical reasons that women are dying here in Georgia. And so I was chair of the Health Equity Committee, and we rolled into the committee, but a lot of the work that we recommended, the recommendations that we made were for to get implicit bias training, right? So that's the other diversity, equity, inclusion, so implicit bias training. So lots of the hospitals, probably over 50% of the hospitals, we have about 60, 70% of the birthing hospitals here in Georgia are engaged in this, in the Perinatal Quality Collaborative. And many of them will have had access to receive training from the collaborative or within their own institutions. So there is an effort around sort of making sure that our providers and staff and nurses who are taking care of Black women and women from, different backgrounds, or at least have some sort of bias training. It is not the end all and be all, but it opens up the door for conversations in these places, in these hospitals, to begin to recognize that Black women, Hispanic women, Native American women, we need attention, and you can't keep doing the same old thing, because we're getting the short end of the stick. And so that we have to address bias. And so you'll hear nurses say, I take care of all of my patients the same way. I don't have bias. I take care of everyone the same. Well, you can't take care of everybody the same. If I'm dying at a higher rate than you are,
Yeah.
So that's not going to work for me, everybody the same.
No.
I'm going to need something a little extra special.
No, that's the same people. I don't see color. We all see color.
You have to. I need you to see color, because that means
look at my name in the chart. They say Javonda, that's a Black lady. It's not Jill. So they already, that just says your bias just already when they see your name is on the armband. Oh, this is a Black lady. She probably gonna have, X, Y, Z, blah, blah, blah. So we all have bias. Just like I walk to a patient room, like they look a certain way, like, probably give me a hard time. May give me a hard time, but just talking about bias when I was in medical school, that was not even discussed.
Yeah, the residency.
So the training definitely is going in the right direction.
Yes.
As we see, more and more females, especially going into OBGYN, which is now dominated. There's more female dominant, especially. It used to not be. That has changed in the past 20 years. It's now more females into OB than males. So I think that also will help, go a long ways in helping with disparate outcomes and having our patients just become more informed. But the team-based approach definitely is a newer approach. That was not the case, at least when I did OB back in the day. In Newark, it was kind of like we were thrown with the midwife for the young moms, and then with the residents for maybe the patients who had Medicaid, and the patients who had private pay we didn't even see.
That's the other thing, the training, there's the 6 residency programs now, and the OBGYN Society, we try to, all of the heads of the residency programs, we meet with them and we talk to them and find out what their needs are and sort of what challenges they're having, and get feedback from them and what are you doing and what you're not doing. So there is a recognition there that included in the training and the curriculum for residency programs, there has to be some focus on racism and diversity, equity and inclusion, implicit bias. I'm working with the ACOG, the region, section, I think it's 4 or 5. They're working on a strategy for the entire region of ACOG here, which includes, West Virginia, I think, Argentina, Georgia, Washington, a bunch of states in this region, and they're working on looking at this respectful care, racism, maternal mortality. So there is an intentional effort, and there's been a lot of conversation around training. And so just know that, everybody's pulling the boat from a different direction. I mean, it's really, we're all paddling, you get all paddles in the same direction. I think that will move the needle, but it's gonna take some time.
Now, I know that some specialties, use patient navigators. Is that common in GYN practice? I know Medicaid would pay for like a patient navigator, patients who, let's say, have a hard time navigating the healthcare system. Like, how do I get to multiple appointments?
Yeah.
We see that sometimes with patients who have, let's say renal failure or who have cancer, they get a patient navigator to kind of help them go through the healthcare system, because it can be daunting if you have to go to multiple specialists. Is that such a thing? Is that exists in GYN care or OB care?
That's something that's starting to happen. I think that there was a pilot program that was happening at Grady. I'm not exactly sure what happened with that, but I know that other states are looking at patient navigators as sort of this model. Again, that's where sort of doulas can fit in, or other types, because again, people see them just as social support, but they can be that linkages to other types of providers or other types of care. So there are some level of that happening. And then with the provider shortage too, what people are thinking about are family medicine docs who are getting and doing OB training as well, because particularly in our rural communities, we know that a huge percent of providers are family medicine docs. And we also know we have a shortage of OB providers. And so having some type of, training for family medicine docs to be able to do OB and then practice in rural communities is another strategy that's happening right now. Again, Georgia's slow to that, but we're working on a whole bunch of different initiatives to put this in full throttle, right? Yeah.
Again, even looking at our
one more
ERs.
question in the chat, and I'll let y'all. We're almost done. There, a question people keep asking: are we properly recording maternal mortality rates here in Georgia? Is the data accurate? Can we trust the data? I don't know.
I think right now the reason why we see higher rates is that we're also knowing how to record them better. And we're going to continue to see the rates get higher. Now, in terms of, Patrice mentioned this distinction between pregnancy associated and pregnancy related. There's been some controversy of whether or not people should consider substance use or opioid overuse as, maternal mortality. And the thing is, it is, because it's happening during your pregnancy. And so that's the way it should be counted. But I know that some states are like, well, I don't know if we should really consider that as a part of our cases because it makes our state look bad. I know that there's been conversations around that, but a death is a death. And I think that we're trying to do better. I think that's why our maternal mortality committees are trying to be more diversified and sort of figuring these things out. But again, there are things related to, lack of resources to be able to count the deaths. We know that some are not going to the coroner, some are not being recorded, or the cause of death is not being related to a maternal death. So we know a lot of those things are still happening. Again, it's when we have better systems, when things are more like, what is it called? Not mainstream, but streamlined. When things are streamlined, then we can get better. But I know Caprice has probably some other thoughts related to that.
No, I think you're right. I think we count all the deaths. Like if a woman dies, we get 50-year-olds on that list. And so we go through all of the deaths in the data because, the pregnancy, when someone dies, it's just checking a box that they were pregnant or not. You'd be surprised how many missed box checks that we have. So we know that we need to make some system changes, but that is reviewed by a group of reviewers, abstractors, we call them, and they review the cases and decide which is a case and what's not a case. And so, yes, Georgia's doing a great job at counting, probably better than a lot of other states, because we've been, like I said, doing it since 2012. We've been doing it for a long time and have gotten better. But all of the deaths that we get from vital records, all of those are reviewed and then decided which ones are, it's not a 50-year-old or, a man, the box was checked incorrectly. So we have pretty good data in Georgia.
And that form is not easy to fill out.
No, it's not.
It's not easy to fill
and then we've had lots of conversation about who's filling that form out. There may be legislation around who fills that form out, how it's filled out, who gets to certify the death, because it's, red tape.
And one thing in Georgia is that I just see practicing down at Grady, all county medical examiners are not the same.
No. And
people think, oh, the Quincy's going to come, they're going to pick up the body, they're going to figure out what happened. Some of them just say, okay, they send them to the morgue. And they don't, they just look at the chart. They don't do a formal autopsy. And really, formal autopsy really has fallen out of favor just because it's expensive.
And I
a lot
think
of times they don't do it. And unless the family presses for it, it won't be done, even though it should be done, but it won't be done.
And then, if anything, if we review any more, we probably have a lot more.
Yeah.
Yeah.
Because you saw
not less,
some,
more.
and some counties, the coroner is also the sheriff.
Exactly.
And
And
they
those
call
are
and say,
issues. Yeah. Those are issues we see in the committee where, particularly our lower income families who can afford an autopsy, and so sometimes things are missed. But I do have to say that we have really great abstractors in the state of Georgia, and we're really grateful to all because they put so much time and work and getting it right. At the committee, we just received this information, but this is a lot of hard work. And now they're actually also, in addition to just looking at review, records, they're also conducting interviews and getting more and learning about with the families and learning about everything that happened. And so that's, again, another unique approach that the state of Georgia is taking that really adds so much value when we're reviewing the cases.
I want to thank you guys for joining us. This has been an impactful conversation. Hopefully we have some people who are on the chat or internet world who are fired up about maternal mortality. And where do we go from here? What are some final thoughts? And just a commercial for our webinar next week. Please join us same time, same bat channel, 7:30 next Thursday for another conversation with different panelists regarding this topic. But let's end on what are our next steps? Where do we go from here, and how do we advocate for ourselves as Black women?
Have to start having the conversation, right? So, Natalie and I, we eat, breathe, drink, sleep this, and we're talking about it with the same people. We need to talk to our community. So you need to talk about it. Tell a mother, tell a sister, tell a friend. Do it in your chapter meetings, your Jack and Jills, your social groups, and your churches, and begin to really elevate this messaging around maternal mortality and what are we dying from, right? So, because I think Black women, we can lift ourselves out of this together. We're strong, we're powerful, but we got to know how to sort of take care of ourselves. So, we listen to one another, like Natalie said, about your hair. Listen to me, sister, about taking care of yourself, about, are you going to the doctor? Are you, seeing someone? How are you feeling? Right? Mm-hmm. My mental is just as important as my physical, and just feeling cared for and nurtured is helpful. So, just really begin to speak more about it. We got to walk for breast cancer and autism and preemies. Listen, we need to be marching for mothers. And so we need everyone really beginning to really shout this from the rooftops and rally around our Black mothers and to do better.
All right, Caprice.
Absolutely.
Natalie.
And invest back in our communities. The way we're, like, Caprice mentioned, rallied up about what happened last year with, George Floyd, is the way we need to be rallied up about what's happening with our Black moms. Be politically involved. Talk to your legislators about, paid parental leave, investing back in our communities, Medicaid expansion and coverage for women that need it, and just really investing in the type of research that can get the things going, where we need to fully understand, again, what are these leading causes, addressing those causes, but then addressing the system level changes. And that takes all of you speaking up for yourselves and speaking up for those that can't speak up for themselves, because we have a lot of women that just feel so deflated around what's going on. We have a mental health crisis that's happening, and we're only going to see maternal mortality actually increase due to COVID, because of interpersonal violence, because of substance overuse, because of, all of these things that are connected to our mental health as well. And so just be a voice for those that can't be a voice, and just stay tuned. And let's not, we're creating a lot of fear. Again, this is something that's, 700 women die, but that's just too many. No one in the richest country in the world should be dying from what should be the most wonderful experience of your life, if that's something you choose to do.
Thank you. And we're going to end there. And again, the message is self-care, be aware, and be empowered. I am my sister's keeper, as I always say. So
absolutely.
If you see someone, help them. It could be you in need of help the next time. Thank you so much for your time. Thank you to our Community World Chapter for hosting this. And please join us next week.
Thank you so much.
Thank you for having us.